Okay. Now, the surgical management of endometriosis. Surgery is a definitive diagnostic and treatment. It is a definitive diagnosis and treatment. Surgery is a definitive one. Okay. So the newer guidelines say that we'll do surgery when there are these conditions. Okay. When there is failure of medical management, when there is very severe pain, when there is severe disease like distortion of pelvic organs and all, and emergency conditions like rupture of endometrioma, abscess, or if there is obstructive uropathy, bowel obstruction. Okay. And endometriosis associated infertility. So these are the conditions where you do surgery. Okay. Post-operative planning and counseling is a key success. Before going into surgery, we should counsel properly because there is reduction of the ovarian volume, recurrences can occur, there is injury to the other organs, infection, possibly if you are doing laparoscopy, it convert into laparotomy. So proper consent on writing all these things and we'll take a consent. Okay. And before surgery, there are physical examinations should be done, and there are proper investigations like some ultrasound to will do. Apart from that, some people will go for extensive endometriosis, pelvic MRI, and ovarian reserve tests will be done. Okay. So these should be educated to the patient, and it is always recommended that endometriosis should be operated by a equipped center. Properly equipped center should be operating this. And other doctors should also be present if there is any bowel or bladder. The other surgeon should be present. Surgical options are laparoscopy and laparotomy. Laparoscopy is a gold standard one. Okay. Coming to conservative surgery is something like if there is endometrioma, we'll just drain the fluid out and we'll keep that. That is the drainage and coagulation conservative one of the thing. It is done generally in young patient with infertility and pain. So first line of surgical option is to conserve the ovaries and hormone production. Less invasive only we should do. Okay, that's about that. And points to ponder in case of infertility is we should avoid the repeat surgery. So once you do surgery, again the pain persists. If you do repeat surgery, the ovarian reserve will be decreased. You should keep that in mind. Repeat surgery can result in 50% reduction in pregnancy rates as well. So repeat surgery should be avoided. Post-operative pregnancy rate in stage 3, 4 is 30 to 67%. So, and yeah, if we leave the patient after surgery, if we leave the patient after 1 year, if she start conceiving, then there is a severe peri-ovarian adhesions and they limit the ovum pickup. So, better go for clear-cut post-operative fertility plans. Um, and IVF, if IVF you want to plan and doing if you want to do surgery, so it is difficult to access the follicle at oocyte retail for endometriomas. These are the conditions like fear of malignancy, rupture of cyst. If these are the conditions, then only you should go for surgery before IVF. Like you could not pick up the oocyte in that way. Or if there is very big cyst and if you do something for ovarian pickup, the cyst may rupture. But in these cases, you will go for surgery before IVF. Then ART is more effective than repeat surgery. Mm, so better go for ART than repeat surgery who are failed to conceive spontaneously after surgery. Okay. And surgical considerations for conservative surgery for pain in endometriosis is we'll remove the tissue, all visible lesions are treated, and proper radiation access should be done. Organ damage, additions should be seen. And post-operatively, if these people are not conceiving only for pain, then they get a Mirena for at least 18 to 24 months to consider prevent recurrence. Okay. Then hysterectomy. Hysterectomy is indicated when adenomyosis is also there and heavy menstrual bleeding is that family completed, and you can go for hysterectomy. If ovaries are removed, the conservation consequences of early menopause and HRT to be needed, they should be explained. Deep infiltrating endometriosis, then the first choice for erectile endometriosis, unifocal, it is better to go for discoidal resection, okay? Because for high bowel lesions, segmental resection should not be chosen. I'm sorry, the squamous lesion should be the first line of choice for unifocal lesion. For high bowel lesions, discoid lesion is not possible. You should do segmental lesions, dissection. Okay, so discoid resection is just for small 3 centimeter lesions, whereas high bowel lesions we should go for segmental resection. Okay. Then, okay. So, once again, I want to report about endometriosis surgical prevention. Surgical management for endometriosis is done in five conditions. What are those five conditions? If there is failed medical management, if there is very severe pain, if there is anatomical distortion, if there is endometriosis rupture, cystic rupture, or tuber ovarian abscess or bowel obstruction, if there is endometriosis associated infertility. Okay. Preoperatively, we'll educate about the ovarian reserve. There is decrease in the ovarian reserve. We'll educate them that. Then laparoscopy is the best choice. And for young patient, we'll conserve the ovary and conservative surgeries are done in young patient. And ovarian tissues should be excessive ovarian resection should not be done. And pregnancy rate after endometriosis resection is 50%. But they should do pregnancy at least 6 to 12 months because there is adhesion formation and there is risk in ovum pickup. And all visible lesions should be properly lysed and additional lysis should be done. Post-operatively, some patient, if they doesn't want any fertility, then they can go for marina insertion. Hysterectomy with other complaints and all, and you should educate about the hormone replacement therapy as well. In deep infiltrating endometriosis, if it is small lesion, then you can go for a discoid resection. If it is more a big lesion, you can go for segmental resection. Next is adenomyosis. Adenomyosis is something like, see, this is the uterus, these are the endometrial cells, and in uterus, in myometrium also these endometrial cells can go. So there is abnormal implantation of endometrial tissue in myometrium. It can be because of invagination or it can be because of metaplasia of stem cells. Okay, and over 40 years, adenomyosis is not typical. Okay, or around 30% of young women are affected, but over 40 years having adenomyosis, it's not a typical one. Symptoms is same like endometriosis. There is dysmenorrhea, dyspareunia, chronic pelvic pain, AUB, infertility, recurrent miscarriages. Mainly recurrent miscarriages is very important. Bladder and bowel symptoms like dysuria and dysphagia is same. Okay. Then investigations, you'll go for ultrasound, that is transvaginal ultrasound, in which you can see uterus is enlarged. Yes, there is asymmetry in the posterior and anterior walls. There is hyperechogenic eye lines of cells, and there is translesional vascularity. There is vascularity in between. Okay, in between there is vascularity in between. It is seen. Okay, and in myometrium, there is anechoic, black anechoic areas in myometrium. And in myometrium, there is fan-shaped structures there. Okay. And in subendothelially, you can see echogenic lines and buds. There is the junction of endometrium and myometrium. There is irregularity. There is thickening of junction. Okay. These are different ultrasound findings. Treatment is very important, minimal side effects. Medical management is also same. You can go for NSAIDs, you can for CS, LNGIS damages. Damages is long-term pain management, post-operative pain management. And LNG-IOS have volume reduction is limited. Like after giving LNG-IOS, it is generally 5 years, but only 2 years it will helpful for volume reduction of adenomyosis. Okay. Next is there is large, there is increased expulsion rates for LNGIOS. Okay. Next is GNH agonist. GNH agonist duration is only should be restricted to 3 to 6 months. We should add the add back therapy as well. Okay. Then GNH antibodies can be given. Aromatase inhibitors are also given. We should add back therapy for them. These also. Danazol given locally, like vaginally, danazol. Intrauterine routes can be given. It reduces the pain in menorrhagia. Okay. Mhm. Even medical management, you should write about HIFU and urinary embolization, very important. Okay, if they ask about medical management of adenomyosis, this everyone thinks that urinary embolization is surgical, but no, it is a medical management. So HIFU is something like high intensity focus ultrasound, and MRGFUS is magnetic resonance guided focus ultrasound. So these are less invasive treatment modalities, patient selection for relief of dysmenorrhea and menorrhagia, and more trials are being going on this safety. UAE is who complete childbearing. They can give effective option of 80% of women, and hysterectomy is avoided in 90% of women. Okay, it's an alternative for hysterectomy. Then surgical management is surgically we can go for like it depends on that, like depends on if there is infertility, implantation failure, or focal adenoma of large than 5 centimeter, dysmenorrhea, IUBs. Then mode of surgery is laparoscopy of laparotomy. Okay, laparotomy may be preferred approach in some patient if there is a uh, it gives a better tactile recognition of the tissue. Laparoscopy may be preferred with well delimited focal one. Okay, so basically you can see adenomyoma at same time, same like a fibroid, only you can see a well, like fibroid doesn't have a well-defined capsule. Like there is no well-defined structure in adenomyoma. There is demarcations are not seen. Okay, so we need to minimize the removal of normal tissue in this. So meticulous suturing of and minimizing the dead space is very important. Okay, blood loss can be minimized by temporary uterine artery occlusion techniques and all we can use, or we can use the medication. Okay, um, during pregnancy, surgery should be avoided, can be associated with uterine rupture and placenta previa spectrum syndrome. So pregnancy should not be planned after at least 3 to 6 months post surgery. Should not plan that. Hysterectomy if there is perimenopausal woman and recurrence rate is less. Okay. Preoperative GnRH agonist if we given, then the size and vascularity blood loss during surgery is decreased, and this facilitates laparoscopy as well because size is decreased. Sometimes during surgery, there is difficulty in delineating the margins and complete excision may be difficult in laparoscopy. Okay, so again, I'll just repeat this. So adenomyosis is abnormal implantation of the tissues, endometrial tissues in the myometrium. 30% young is affected. Symptoms are same as endometriosis. And in ultrasound, you can see that uterus is big and large. There is asymmetry in the anterior and posterior walls. Hyperechogenical islands and translesional vascularity is seen. And you can see the irregular junctions, fan-shaped shadowings, echogenic lines and buds. Okay. First, medical management, you have NSAIDs, COC pills, LNG-IS diagnosis, and you can have GNH agonists as well. GNH antagonists can be given, and aromatase inhibitors like anastrozole, letrozole can be given. Danazol can be given vaginally or intrarenally. High focused ultrasound and MRI focused ultrasound, urinary embolization, where there is 80% women, there is effective option. It is also a medical management. Then coming to surgical management, focal adenoma or infertility is better. Laparoscopy is a preferred approach, and you should suture the dead space as well. Uterine temporary occlusion can be done to prevent the blood loss. Surgery associated with complications during pregnancy, like uterine rupture and placenta previa, so should not plan at least 6 months after surgery. GnRH, if it is used, then the size of the adenomyomas is reduced, and preferable laparoscopy can be done. Infertility and pregnancy. So, repeated implantation failure should be screened for adenomyosis. If the patient having a repeatedly implantation, then failure, then there is adenomyoma. Adenomyosis and pregnancy should be like if there is adenomyoma and she got pregnant, then she have a risk of miscarriage, preterm delivery, placental disorders, even hypertensive disorders, preeclampsia, postpartum hemorrhage are high. Okay. Now coming to next topic is scar endometriosis. I'll tell you next one. Yeah, yeah, we can tell. We can continue. Okay, scar endometriosis. Scar endometriosis is something like it's a common gynecological abdominal wall endometriosis, common gynecological procedure. Like if you see laparoscopy, cesarean section, appendicectomy, abdominal hysterectomy, in these scars you can see the endometrial tissue. Okay. So that's the thing. And average time, like if there is surgery and getting into scarring endometriosis is 3.5 years, almost 3.5 years. Okay, incidence is 0.03 to 1.5%. Okay, episiotomy endometriosis is very less, 0.01%. So symptoms of scar endometriosis is there is cyclical changes in the size and intensity of the pain on the scar. Okay, there is hypertrophic and hyperpigmented scar as well because of hemosiderin deposition inside the scar. Management is you can go for actually surgical removal is the preferred treatment, but hormonal treatment, medical management can be given. Okay, by and in surgery also therapeutic management is wide local surgical excision, and we can give hormonal treatment like progestin, dosipris, anosology, as agonist, analgesic. Okay, and there is no effect on size of the lesion, same like adenomyosis and endometriosis. Recurrence of scar endometriosis is seen. Recurrence is seen in almost 4.3%. And how to prevent it? While suturing the, like in LSAS cesarean incision, while suturing the incision, we should avoid the deciduea. Okay. And you should use different mops and needle for inside the uterus. And irrigation of adipose layer and fascia during closure also you should irrigate. You should clean. Okay. Hmm. That's it. That's about cardiomyocytosis. So incidence is very important. Incidence is 0.03 and recurrence is 4.3. And average time between surgery and endometriosis 3.6 years. Much? 3.6 years. Endometriosis and malignancy. It's a chronic inflammatory disease and there is a chance of malignancy in them. And they will ask in ovary what is the high risk? It is COX. That is ovarian cancer, clear cell, odontoic carcinoma, clear cell, odontoic carcinoma, odontogenic carcinoma. Okay, other cancers also like endometrial, breast, thyroid cancer can also be seen. And clinicians should advise them to see what is the cancer preventing strategies like avoid smoking, healthy diet, balanced diet, fruits, vegetables, alcohol should be avoided, sun protection should be taken. These all should be advised to them. Since there is only slight increase in the risk of ovarian cancer, routine screening with CA125 is not recommended. Okay. Then diagnosis of ovarian malignancy, ultrasound is the best method. MRI can be given with high specificity. Surgery of malignancy can reduce the risk of subsequent ovarian cancer, and removal of that affected ovary is done. In endometriosis involving the both ovaries, then BSO should be done in caution with it, which reduce the risk. Next, coming to menopause and endometriosis. I told you, menopause, people have that extra ovarian production of estrogen, adipose tissue, so there is 22 to 5% of endometriosis in them. Medical management, like mainly aromatase inhibitors, is given, and how you'll diagnose that this postmenopausal woman having pain is because of endometriosis is histological diagnosis. HPE only, it's a confirmation test. Hmm. What is the incidence? 2 to 5%. That is important. Then menopausal symptoms in the endometriosis, we can give combined MHD. Should be continued at least the age of natural menopause. Menopausal symptoms can be seen. Then menopause related major issues, health concerns. Then you'll go. Basically, people will get a hysterectomy for different reasons, and even BSO is done. So for them, screening for cardiovascular diseases, we should monitor diet, lifestyle modification, and all. Fertility preservation is generally after endometriosis, there is rapid decline of serum AMH. Generally, 26% say it will become to 7.4%. Okay, so I'll tell about the flow charts now. Mm, so recurrent endometriosis. So first thing is these are the these no dysmenorrhea, dyspareunia, dysuria, dysesthesia, all this pelvic pain. These are all recurrently if they're coming, and there is clinically you have pelvic fibrotic tender nodules, and radiologically also you have endometriosis, and repeat CA1 to 25 is also raising. Then you will see the symptoms. First thing what you'll see, you'll see the symptoms. Pain symptom, infertility pain, desires for fertility. So pain symptoms are present, then you'll give this medical management, diagnosis, medical management refractory, then you'll go for surgical management. If there is infertility plus pain, then you'll go for ART and surgical management. You okay? If she's desiring of fertility, then you can go for IVF ICSI or and this thing injection generate agonist reports. Post delivery, you should go for medical suppression. Okay. That's it. So in recurrent endometriosis, you will see the symptoms, pain symptom, then you'll go for medical management, pain, then surgical management, infertility pain, then you'll go for IRT, desires of fertility, there is no pain, then you can go for ICSI or IVF. Coming to deep infiltrating endometriosis, what is the definition of deep infiltrating means? Mm, like more than 5 mm. What? more than 5 mm if the endometrial lesion is present. Under the peritoneal surface, if these lesions are present, that is known as adenomyosis externa. Okay. The 5 mm definition allows the understanding of lightly deeper classical lesions type 1. So, more suitable to define that DIE is as adenomyosis externa with unique lesions. Okay, so in 2 or 3 with more than 1 centimeter, then there are type 2, type 3 lesions. So, type 1 is generally 5 mm. So, according to recent analysis, DIE is defined as infiltration of fibrous and muscular tissues in organs and anatomical structures affecting the endometriosis. Okay, most aggressive form of endometriosis is DIE. It affects almost 20% of women. So, localization of symptoms and lesions and symptoms are all the ligaments, even the cornices, and symptoms of dyspareunia, dysmenorrhea, bladder symptoms, urinary symptoms is seen. Ureter also sometimes get obstructed. Hematuria is seen. Bowel symptoms are seen. Okay, painful defecation is seen. Management protocols of DI is medical management. You'll give these things like oral contraceptives, gonadotropin releasing hormones, danazol, aromatase inhibitors. Surgical management, if the medical management fails, the same thing. Okay. Mm, see, main important thing in surgical management is we'll remove the endometriotic tissue, but as it is deep infiltrating, uh, then, like for example, hydronephrosis caused by ureteral stenosis or intestinal obstruction. So we should eradicate a whole pathology, and you should have a good long-term outcome. No? So we should do with respect to the functional anatomy of the organs. Nerve-sparing laparoscopic techniques are done for urinary and bowel function, and uterine and bladder endometriosis. Then mainly the urethral endometriosis can be conservative and more aggressive thing like ureterostomy, ureteroneostomy, and nephrectomy can be done. Mm, okay. So, okay. During laparoscopic cystectomy, the decision to perform urethral cannulation it depends upon the endometric nodule position in the bladder wall and distance from the intrauretic ridge. Okay, depends on that. If it is very close and obstructing, then better go for urethral cannulation. It is urethral catheterization. That's it. So same thing is being repeated. Everyone says some first line drugs, second line drugs, and all. So COC pills, progesterones, these are first line hormonal drugs. Even Dynages is first line. Second is agonist and antagonist. Third line is aromatase inhibitors. Okay. Side effects of aromatase inhibitors you should learn: arthalgia, myalgia, and decreased bone mineral density. Okay. Antagonist and agonist like you can go for hot flushes are seen, and hormones you have irregular bleeding, breast tenderness, vomitings, and nausea. NSAIDs you have gastric ulcers, kidney disease, and bronchospasm. That's it. Thank you.